I'm very pleased to have yet another opportunity to speak to a cohort of first-year students. And I really want to thank your course coordinators for making that possible, but more especially, I want to thank yourselves for choosing to spend this hour with me. And I really want you to not look on this as a lecture, but rather as a unique opportunity to get some insights into what it is like to be a patient, a family member, and a clinician when things go wrong, and things do go wrong. I present to many diverse groups, but I'm very, very definite about the fact that I feel like I get the greatest buzz out of speaking to people like yourselves, students who are starting out on your careers. I find students both at home and abroad to be idealistic, highly motivated young people, and I certainly hope that you will retain those core qualities as you progress through your career in future years. And I say this very sincerely because I feel strongly that if during your training you are exposed to the patient experience, while you were being trained as healthcare professionals, and that you also develop some kind of appreciation of the value of the patient experience, coupled with an awareness of what really constitutes truly patient-centred care. And I would say that care is only patient-centred when it is perceived as such by the patient. That is actually your litmus test. This is a very important time in your professional lives. The foundations are being laid in relation to your work practices, techniques, professional conduct, interpersonal relationships, communication, ethics, all of those very important things. But I'd like you to remember that you're actually very privileged young people. You have been blessed with high-grade intellect. You're benefiting from superb training. But most importantly, going forward in your careers, you will be gifted with the opportunity to serve humankind on a daily basis. And that is truly awesome. And this should be really a very humbling experience with the potential to allow you live very fulfilled and satisfying lives. So what I will do is I will speak about the patient perspective and patient expectations in relation to both the care he receives and the quality of the interactions in particular with the individuals he encounters during that process. And I suppose in that regard, it's interesting to look at a piece of work the Medical Council did quite recently. It was a survey of perceptions of the Irish people in relation to the different professions. And that survey revealed that 88% of the respondents trust their doctors to tell the truth. Now, I wasn't at all surprised by that finding because, as far as I'm concerned, you are the people who hold our lives in your hands and whom we patients really want to be able to hold in high regard. And isn't it then all the more unacceptable when that very high level of trust can sometimes be betrayed? Patients present for diagnosis and treatment when at our most vulnerable and least assertive. Our expectation of safe healthcare is a legitimate expectation, and our hope is that each one of you would, in your everyday work, do the best thing possible, give us the best care possible, in fact, the kind of care that you would extend to a family member, your own mum or dad, sister, brother, best friend. And it's also important to remember that the patient is the single entity that is present throughout the full continuum of care. And as well, that patient does see things through a different lens. They can be a wonderful resource and have certainly very valuable input to the care pathway. And most importantly, the patient is the one individual who has the greatest vested interest in the outcome. So consequently, our confidence in the system and in the individuals is best achieved when we do see adherence to guidance, protocols, best practice, and even more importantly, when you listen to what we have to tell you. And because translation of research into practice can often take as long as 14 years, we ask that the knowledge we do have in the here and now be put in place, that you would use what we now know. And that doesn't necessarily call for huge financial investment, but rather is much about reflective learning and having the resolve to do the best thing possible. So now all of that is very fine, but where do I, Margaret Murphy, fit into all of this? Well, I am the external lead of the WHO Patients for Patient Safety programme, and that advocates for a culture of safe care that is more inclusive of patient and family. And like many others, I have undertaken advocacy work because of a negative experience of healthcare, the needless death through medical error of my own 21-year-old son, Kevin. And two aspects of that experience, if you like, have influenced my resolve to be a collaborative partner in the change process which might make healthcare safer for future patients. One was that every point of contact in the Irish system failed him, and secondly, that injury was further compounded by the very real fact that learning opportunities were frustrated by damage limitation efforts after his death. And I would contend that the duty of care to the patient doesn't end with the death of that patient. So a burning question for me has become, can a tragic outcome be a catalyst for change in an improved health service? And you might put the question, well, why would we listen to the likes of Margaret Murphy? She's a layperson. We will be highly trained professionals. So in response to that, I give you the Indian proverb, tell me a fact and I'll learn. Tell me a truth and I'll believe. Tell me a story and it will live in my heart forever. And patients like my Kevin certainly have powerful stories to tell. Simple measures save lives. Simple measures were not taken and Kevin lost his life. As I say, every point of contact failed him. But it's very often the case that in the acutely ill patient, there is a long antecedent period during which successful intervention is possible. And that period, in Kevin's case, extended over almost 2 years. But nobody took advantage of that. So I offer you the ultimate data in relation to Kevin. It's his death certificate. It lists multi-organ failure, hypercalcemia, parathyroid tumour. Now, people do not die from primary hyperparathyroidism, especially when blood tests revealed high levels of calcium almost 2 years before his death. I take it you're not familiar with the condition. Behind our thyroid glands, we have 4 parathyroids, and they control how the chemicals are distributed throughout our body. And sometimes you can have an adenoma on one of those glands. And this was the case with Kevin, and it was causing calcium to be diverted into his bloodstream rather than into his bones. And the result of that was that his bones were softening while the viscosity of his blood was being altered and putting a huge strain on his heart. Well, adverse events happen to real people. Kevin was more than a statistic. He was more than a medical condition. He was a young man, 21 years of age, and I imagine if he were sitting in one of those empty seats next to you, he wouldn't be at all out of place. He certainly knew how to push all his mother's buttons. I could be proud of him, I could be disappointed in him, he could make me happy, he could make me cry. But more than anything else, he was my beautiful boy, handsome, strong, carefree. And I'd just like to share an instance with you. It was the January when he was completing his CAO form for college, and he had been talking about medicine. And when he came down from his room, I said to him, well, Kevin, what have you finally decided? And he said, oh, electrical engineering. I've lost my, I've lost my mic piece. It wasn't anchored properly. I'm really sorry about this.
We can leave it up here.
I nearly have to undress.
Just pop it up on. Just pop it up there.
Really sorry about that. So I said to him, you'd been talking about medicine. Why not that? And he said, I'd be afraid I'd make a mistake and somebody might die. Now that was to be his own fate almost 4 years later. So I salute you, each of you, who has chosen to go where Kevin feared to tread. Kevin was admitted to hospital 8 days after this picture was taken. 3 days following that, his sister, here pictured with him, and I sat at his bedside in ICU. Kevin had died right before our eyes. Nothing or no one had prepared us for this. We had questions, we needed answers. They were very simple questions. How does a young man go to hospital on Thursday and be dead on Sunday? What went wrong? We need to know, we need to understand. What we experienced was closing ranks, lame excuses, muddying of the waters, and protestations of loyalty to colleagues. So, disappointed and frustrated, we retraced his medical history over the previous 3 years. We had to do that without any support. And the story slowly and painfully unfolded. The failings were many in number, they were serious in nature, they were indicative of system breakdown. That was then compounded by misdiagnosis, inappropriate treatment and management, together with issues of communication and data handling. And in particular, I'd like you to keep in mind how laboratory results were mishandled, how those results provided sufficient data which, if interpreted correctly and acted upon promptly, would certainly have saved his life. And in fact, the potential to achieve proper diagnosis and treatment was sabotaged. It was sabotaged by a combination of filtering of test results and inaction. And all of that happened right across the system, from primary care level right through to the treatment afforded him in a tertiary training hospital. And that's why I say every point of contact failed him. Now, during 1997, Kevin presented on a number of occasions with persistent back pain. Without any improvement, he was referred to an orthopaedic consultant in the autumn of that year, and blood tests revealed high levels of calcium at 3.51 in a normal, very narrow range of 2.05 to 2.75. Other parameters were also raised, and all of those abnormal results were underlined in the laboratory report. But when writing to the GP, the consultant really underplayed the high calcium levels and made no reference at all to a plasma creatinine level, which at that point already indicated more than 50% loss of overall renal function. Now, that letter isn't on the GP file. So as a consequence, Kevin wasn't aware that the consultant wished to see him again early in the new year. We know the letter was written. We don't know if it was sent. We don't know if it arrived. All we really do know is that letter was certainly not acted upon. And it's also significant that throughout his care, only one set of clinical eyes saw those very important test results. At no point in his care was the hard copy forwarded to another clinician, and neither did it travel with Kevin himself as part of a patient-held record. And I'd be a real advocate of patient-held records. Certainly, we wouldn't necessarily be able to interpret what is contained in them, but we could spot things which would, if you like, encourage us to ask questions. And we would certainly have spotted things when we had access to the files after his death. We plotted all the test results. Now, we couldn't interpret them, but it was very clear that something very significant was happening. And we would have asked questions about that, and nobody was acting on the basis of that. So no one else, patient or clinician, had the opportunity to revisit them and give the patient the benefit of a second pair of eyes. The opportunity to initiate best practice was lost. It was lost by not recognising the seriousness of his condition, the absence of a system to flag the high calcium readings and instigate action, and not communicating the test results in their entirety, and again, preventing the patient from having the benefit of that second pair of eyes. Kevin's file contains a notation by the doctor's secretary. Telephone call from patient's mother. She's extremely worried about her son. She wishes you to know that she thinks he may be depressed also, failed his first year exams, failing and not doing well either, finding it hard to study. He's now remaining in bed a lot. Now, this was from a really bright young man. She has arranged an appointment with Dr. X's psychiatrist tomorrow and would like to have the results of the blood test, the bone scan, for consultation. She wonders if he really has a back problem. What will I tell the mother? The results on file. She wished to speak to you. And the doctor's response? Fax results to Dr. X. There was no communication with the mother. There was no communication with the patient. And that is why I say you ignore at your peril the concerns of a mother. I can certainly assure you that that umbilical cord is never totally severed. Carers and family members are often dismissed as being over-anxious. The patient and family are critical components to the integrated care process. And my understanding is that one of the aims of an integrated care pathway is to improve that clinician-patient relationship. And sadly, very often, the patient is the piece that is very often left out of that puzzle. The informed patient is a resource and does have the potential to be a positive partner. The report of the Irish Commission on Patient Safety and Quality Assurance describes a patient safety framework as knowledgeable patients receiving safe and effective care from skilled professionals in appropriate environments and with assessed outcomes. Michael Leonard, physician leader at Kaiser Permanente in the United States, describes a patient safety culture as one where no one is ever hesitant to speak up regarding the well-being of a patient. And everyone has a high degree of confidence that their concern will be heard respectfully and acted upon. So even as junior members, you are entitled to have your voice heard if you are concerned about a patient and in how that patient is being managed. So as a family, we trusted the healthcare system and we trusted healthcare professionals, and after repeated consultations, Kevin was returned to us as seemingly healthy. And I suppose in many ways, we too, his mum and dad, joined the ranks of those who failed him, in that we trusted the healthcare professionals and we, if you like, interpreted a lot of his uncharacteristic behaviour as Kevin, if you like, flexing his muscles in his late teen years. And we operated tough love at a time when he, in fact, needed TLC and appropriate medical treatment. Now, when commenting on the quality of Kevin's care in the autumn of '97, peer reviewers later said, Kevin would have had surgery to remove the overactive parathyroid gland, he would have been cured and would still have been alive today. And you can see the other comments. That is also supported by research, which tells us that the procedure has a 96% success rate with a 1% complication rate. So there were certainly very, very significant odds in Kevin's favour. But you could say that nobody was at the races. And our family experience also bears that out, because 3 months after Kevin's death, his dad was discovered to have the very same levels of calcium with which Kevin first was presented. And we saw him have the procedure, which Kevin should have enjoyed, and he is alive and well today. The condition can be familial, and as recently as last October, his sister also had surgery, and she is doing well. But the necessary referral to an endocrinologist did not happen. The diagnosis of primary hyperparathyroidism was not made, and hypercalcemia was allowed to progress for a further year and 10 months, by which time it was described as inconsistent with life and was at a level higher than any ever recorded in Cork University Hospital. So Kevin spent the summer of 1999 in the United States on his J1 visa. On his return, he attended the GP, still complaining of lethargy, occasional vomiting and continuing bone pain. Blood and urine samples were taken, and the test results were telephoned to the GP surgery the next day. And they were written on this post-it note by the practice nurse. And you can now see that they have gone to 5.73. We're off the Richter scale at this point. However, another key point of contact failed Kevin because the GP totally ignored the high calcium levels and only included in his letter of referral to the hospital those elements of the blood test which supported his own differential diagnosis of leptospirosis. Despite the fact that the nurse had brought her little handbook into him and actually suggested the diagnosis of hypercalcemia. We later learned that that particular GP had experienced some success in diagnosing leptospirosis. So he was hanging all his efforts on if you like, the renal and the plasma creatinine results. And I suppose you could say that you know how experience can serve you well, but you could say that at that point in time, experience didn't serve that doctor well. He didn't keep an open mind. It caused tunnel vision for him. And there is the expression of life hanging on a thread. Well, you could also say that at that particular point in time, Kevin's life was hanging on something as simple as a post-it note, piece of paper, much the size. Now, in fairness, he did send the post-it note with the referral letter, but again, things went somewhat awry in that in the hospital, they didn't want that piece of paper to be lost, so that post-it note was stuck to the back of the letter and wasn't seen until 6 weeks after Kevin's death. The hospital itself, its regular protocol for blood tests didn't include for calcium. Calcium would have been a special request. So as a result, his high calcium levels were not known to those caring for him in the hospital. No medical personnel seemed to appreciate how ill he had become. His condition deteriorated rapidly. And I recall speaking with the consultant in the hospital corridor, and there was the plan to transfer him to Cork University Hospital on renal grounds. And I said, "Are you concerned at all about the delay in his transfer? Because I have this desperate sense of urgency." The umbilical cord kicking in again. And Kevin's brother was there, and he said, "And what will they do differently in CUH?" And he said, "Oh, they'll do nothing differently. Perhaps they'll take a biopsy Monday or Tuesday." We were speaking on Saturday. Kevin was dead on Sunday. For Kevin, there was no Monday. For Kevin, there was no Tuesday. Despite his continuing decline, no alarm was raised. He became dehydrated, described muscle pain and neurological problems. His medical notes quote him as saying, "I have crazy thoughts coming into my head." And those notes also showed the advancing renal failure, and 2 crucial days were lost during his stay in that hospital. In fact, he was a textbook case of primary hyperparathyroidism. Moans, bones, groans. He didn't have the stones. There was just one element missing, but he was heading that way. As I say, every point of contact failed him. Finally, he was transferred to Cork University Hospital, and it was here that we first heard concerns about calcium in relation to Kevin. In almost 2 years, we had never heard the word calcium, and the levels were now at 6.1. Unfortunately, it was the weekend. He was managed at registrar level. Senior personnel were available on call, but they were not called. And I suppose I have to be honest and say that I don't know if there would have been a better outcome, but I certainly think it would be good for me, his mum, to know that at least he was given every chance. And that certainly did not happen. During Sunday, he was lucid, he was very sleepy. He was in ICU, he couldn't see the television, his sister was telling him what was going on. He was a great Formula One fan, and he wasn't at all pleased when Jordan were knocked out. And, you know, he really was quite lucid. Then the All-Ireland came on, and she was telling him what had happened. And again, no one intimated that his life was in danger. So his dad and brother decided to go back home and watch the match with the plan that they would come back at tea time and his sister and I would then go home. They just left the room. The SHO came across, had a look at Kevin, and he turned away. And before he reached the door of the ICU, Kevin suffered a massive heart attack and died as his sister and I sat at the bedside. So we were ushered out. We need to work on him. I sent her running through the hospital corridors, and it all happened so quickly that she actually caught up with her dad and brother before they reached the car in the car park. So a short while later, a nurse and a doctor came out to us and said, we need to talk to you. We have a room over here. And I recall looking at her and saying, it's not good that you're taking us to this room. And when we went in, the doctor said, Kevin was very sick. And I said, is he gone? And he nodded. He said, yes. And immediately, I certainly know where the words came from because Kevin carried a donor card. And immediately I said, what about organ donation? And he shook his head. Kevin had been allowed to deteriorate to the point where his organs were of no use to any other human being. And to me, that was like Kevin dying twice. And the doctor was a kindly man. He saw the effect that was having on us. And he said, would you like us to inquire about his eyes? And I said, yes. So his corneas were donated, and we later learned that a 60-year-old man and a 42-year-old woman now have sight. And that is Kevin's patient journey. And when we reflect on the journey, we can certainly identify the many shortcomings that contributed to such a tragic outcome. There was the inability to recognise the seriousness of his condition, appropriate interventions weren't taken, there was selective and incomplete transmission of information, non-receiving of vital information. I would certainly say if you're sending something of importance to a colleague, the least you need to be assured of is that it has arrived at its destination. There was no integrated care pathway. The link between his behaviour and test results wasn't made. His developing neurological problems were ignored, and there was no evidence of tracking of his deteriorating condition. And that was evident to anybody who would actually plot those results. And there was absence of direct communication with the patient. There was his treatment at registrar level. Why did that registrar not call? There was the team dynamic. How come somebody else in the team didn't say, well, if you're not calling, I'll call? And I certainly remember 3 months later, after my husband's surgery, I went to see his surgeon. And I psyched myself up beforehand that I'm not to mention Kevin. This is about Barry, it's not about Kevin. But it was the doctor who raised the issue of Kevin. And he said to me, I'm really sorry about your son, Mrs. Murphy. I could have done something for him that weekend. So he highlighted 2 things. He could have done something had he been called. I entreat you to make the call. Sometimes it can be difficult. Sometimes you may not be well received, but it's important that you make the call. He also highlighted the weekend as a time when maybe things aren't as well in place as they are Monday to Friday. That's the time you need to really look out for deterioration in your patient and respond to that. There was, and in fact, we talk about patient-centred care, and when you look at it, wasn't the patient really asked to accommodate the system? Please stay alive until Monday, and Kevin just couldn't do that. And our expectations of a tertiary training hospital certainly were not met. And then in the aftermath, what happened in the aftermath? What is a decent response? Yes, there were initial honest and humane reactions from individuals. In particular, I remember the nurse. She sat at the bedside with me. She was crying as freely as I was. She was stroking my arm. And I said to her, but don't you see this every day? And she said, oh no, not that. That should never have happened. She nailed it. She said it as it was. She didn't try to make it more palatable. Very hard to hear, but it was necessary that it be said. And in a very short space of time, all of that was replaced by a process of damage limitation. One doctor described his dilemma as an issue of loyalty to colleagues. And I'll bring up the post-it note. It was a really significant day. We actually met 3 very significant people in one day. And the first one was a head of department. And he said that in relation to the post-it note, that even if his consultant colleague had seen it, it wouldn't have meant anything to him. And I said, why not? I said, may I have a look at it? And I looked at it again, and I couldn't see any issues. So then it suddenly dawned on me, and I said, are you saying that because it's not written in scientific notation, it wouldn't mean anything to somebody like you? And the man actually said yes. A suggestion that CAL might not mean calcium, POT might not mean potassium, and SOD might not mean sodium, and they all in each other's company. And I have to say it was at that point that I lost faith, because I saw it as a pretty feeble attempt to put the blame on the nurse and to get rid of me. I was to conclude, oh dear, if only the nurse had written it properly. And I was sorely disappointed with that. So, as you can imagine, our hope of ascertaining the truth through honest dialogue was certainly shattered. And that is why we, a family not at all given to litigation, did have to go that route and pursue litigation. It also became clear that the legal system favours the defendant in these cases, especially in the areas of finance and resources. For ordinary people like ourselves, it was a David and Goliath experience. Until the 11th hour, every effort was made to settle without admission of liability. A wearing down process that lacks compassion, it lacks consideration for heartbroken people. Cases like ours really do need to be heard in a non-adversarial environment where the focus is not on blame, but rather on ascertaining the truth, seeing what happened, identifying things that need to be improved, and above all, preventing recurrence, learning from the tragedy. Open disclosure has to be the part of the culture of each organisation if learning and improvement are to be achieved. Disclosure is not about blame. It's not about apportioning blame. It's not about accepting blame. It's about integrity, and it's about being truly professional. And that's the path you're on. You're on a path of professionalism. And this is what is required of you. Honesty trumps all else. We can't change the past. I'd love to change the past. But what we can do is we can use the past to inform the present. And then in the present, can't we then make the future better? And we can only do that if we have this culture of openness and honesty and learning. Almost 5 years later, a judge of the High Court declared, it is very clear to me that Kevin Murphy should not have died. 2 GPs, a private consultant, a hospital consultant, and a hospital, all admitted liability, expressed their regret at Kevin's death, and sympathised with us as a family. Now, sadly, that was done through legal representatives, not in person. So the ownership of that apology, I really don't know how robust that is. Certainly that all of that information could have been made available by about 6 weeks to 2 months after Kevin's death, and that would have avoided almost 5 years of trauma and uncertainty brought about by the litigation process. And the focus of the hospital, if you like, was on defending a lawsuit rather than on actually making improvements which would benefit future patients. Monetary compensation was never an issue for us as a family. I grew quite tired of having to defend, if you like, the fact that we were going to litigation. The sum of money doesn't exist that would equate to my Kevin. Neither could we imagine any circumstances in which we would derive benefit or pleasure from such money. So we donated the settlement figure to 2 charities. I couldn't buy a car. I couldn't go on a holiday. I couldn't do home improvements. So Boher and the Make-A-Wish Foundation benefited from that settlement. So as patients, we can't give permission for error. You see how we were treated as a family, but how does healthcare treat members of its own staff? We do understand that the practice of medicine is complex, that it's risk-laden, and I accept unreservedly that no one intended harm to Kevin. And I remember that same day, the day I spoke of, we met that young SHO in the corridor, and he came across, he recognised us, and he came across and he said, "How are you doing, Mr. and Mrs. Murphy? Kevin was very unlucky." And I was shocked. Unlucky? Last year of the millennium, in a first world country, in a tertiary training hospital, and we're using the word lucky or unlucky? And I was mad. But I wasn't mad at him. I was mad at the organisation that left him with such a superficial understanding. And the reason I wasn't mad at him was because I really liked him. And the reason I liked him was because on the afternoon of Kevin's death, as you can appreciate, Kevin's friends assembled in the hospital. They were sitting in the corridors, head in hands, trying to come to terms with what had happened. And he passed by. And what did he do? He took off his white coat, the barrier. He balled it up and he put it on the ground next to them and he sat with them. An amazing act of solidarity. Now, you can't teach a fella to do that. That's not in any textbook. That came from deep inside that young man, a decent young man. There was also the very strong possibility that he was being encouraged by his peers and by his superiors. You have to get back up on the horse. Of course he would. He'd have to get back up on the horse. But there are some horses you need a bit of a leg up. And I'm not so sure that anybody was giving him that leg up that he needed. But he did deserve better than a superficial understanding. We met another individual on that day. We were coming out of the lift, and just as the door opened, a man entered. It was the registrar, the man who should have made the call and didn't make the call. And he's looking at me and trying to place me. I know him. And all I say to him is, "I'm Kevin Murphy's mother." And his face changed, and he blurted out the words, "I didn't think he'd die." And he backed out of the lift, and he ran away down the corridor. And I turned to my husband. Now, remember, we had just come from the man with the nonsense about the posted note. And I said to him, "Oh my God, they've abandoned us, but they've abandoned him too." Certainly, he should have made the call, but he didn't deserve to be in that condition. Where did he go? Did he have someone to talk to? What supports did he have? I suspect little or none. And there's something wrong about that. It's about supporting patient, family, and clinician when things go wrong. And it certainly reminds me of the story in the United States of Dr. Rick Van Pelt and the patient. And he was advised, he was an anesthesiologist, and he was advised to not make contact with her after the event. And but he was known as Iceman when he was in college, so you know the kind of individual we're talking about. But he had this burning desire to speak with her, to explain to her, and everybody said no. But eventually he did. And sure, they did have a difficult first meeting, the doctor and the woman he almost killed. But he said that on that day, and he says it with great relief, I've heard him at conferences, on that day an 800-pound gorilla got off my back. Now that's some image. 24/7, an 800-pound gorilla on your back, and you can get shut of it by having a decent and honourable conversation with another human being. So that's what I'm asking you to do, to not be storing monkeys or gorillas on your back, to be honest and open with your patients. So I suppose I have learned something from all of this, and I've my Margaret Murphy wish list, which says things like observe existing guidelines, safe operating procedures, be prepared to challenge each other. The best gift you can give a colleague is to make sure that they're doing as well as they really can do. Listen to and respect patients and families. Know your personal limitations. Real wisdom. Keep impeccable records, refer constantly to them and act on them. Communicate effectively, acknowledge error and allow the learning to occur. Following adverse outcomes, undertake the root cause analysis. Replicate what is good and identify opportunities to improve. Learn, disseminate the learning, practice dialogue and collaboration, meaningful engagement with patients and families. Create that coalition of healthcare professionals and patients. And that's happening now. We now have a cohort of Irish patient safety champions who are working with the HSE and the Department of Health, bringing the patient voice. And above all, be honest and open and seize the opportunity to give some meaning to tragedy. And Sir Liam Donaldson describes the 5 most dangerous words as it could not happen here. It can certainly happen anywhere, anytime, to anyone. Following adverse events, there is a window of opportunity. Albert Wu calls it the golden moment, and that is often lost because of the inappropriate responses and the defensiveness, the expressed loyalty to colleagues and to an organisation, and to shoring up, if you like, a flawed system. The result is confrontation and litigation, and the barriers to open communication have been to that really good way forward are the inappropriate responses, the inaccessibility of partnership and collaborative opportunities, the culture of medical practice, this expectation of faultless performance. No human being can deliver on that, to be right, 100% right, 100% of the time. What you have to do is have systems in place that will mitigate the possibility of error, and then when an error inevitably occurs, to also make sure that there is learning from it through the acknowledgement and the openness. Fears relating to litigation and loss of reputation, excluding the patient and family from the change process, and neglecting to learn from industry. I have a daughter in the medical devices industry and a son in the pharmaceutical industry, and they have corrective action reports. Nobody's sacked for making a mistake. Nobody gets a rollicking for making a mistake. They get sacked and they get the rollicking for hiding the mistake, because that is seen as sabotaging the industry. And I suppose that's why my first encounter with Sir Liam Donaldson, Chair of the World Alliance, was such a revelation. I remember him that day in London in Whitehall. He walked into the room, extended his hand, and he said, "Hello, Margaret, I'm Liam Donaldson, sit down and talk to me." These words from a knight of the realm. And that's exactly what happened. Talk to me. In 5 long years, no one had said, "Talk to me." And he listened and he heard, and there's a difference. He acknowledged that something happened that shouldn't have happened. He didn't offer excuses. And then he enumerated on his fingertips the number of missed opportunities. And he likened Kevin's case to Jim Reason's Swiss cheese model, where you can see if all the possibilities for error, the holes in the Swiss cheese are lined up, well, then disaster has a free run through. And I remember in a moment of kind of dark humour, I said to him, "Well, stuff your old Swiss cheese model. I'd like to see a fine, decent block of Irish cheddar that will let nothing at all through." And really, I then returned home to Ireland a considerably healed woman, conscious of acknowledgement, conscious of being heard, and above all, conscious of the possibility of being part of the change process. And what did he do? What magic did he do? He validated the patient experience. And you have to validate the experience, and you have to learn from it. And I've told you about Rick Van Pelt and Linda Kenny, and they went on to work together, and they set up MITSS, Medically Induced Trauma Support Services, which supports patient, family, and clinician when things go wrong. So insensitive responses to patients actually create new patients. The trauma arising from how we are received can actually often be more damaging than the event itself. And such conduct does undermine public confidence in the integrity of those professionals who do hold our lives in your hands. and who we really do want to hold in high regard. And I suppose probably one of the first things we have to do is examine and get some understanding of why do essentially decent and professional people often behave in a very inhumane way in the aftermath of an adverse event. Now, the open disclosure policy, the national policy, has been launched recently, but you can launch all the policies in the world. They're of no use until such time as they're implemented, until such time as they become the norm, until such time as they're embedded in the system and are part of how things are done around here. And you, the new cohort, I see you as a wonderful resource, a wonderful opportunity to bring about sustainable culture change. It is you young people can actually achieve that. So my personal experience of collaboration has spanned the international, national and local arenas, and none of it would come about were it not for the people in healthcare who give me the opportunities, give me the invitation. And to me, they're a bit like the visionaries that Helen Keller described. She says there's one thing worse than being blind, and that's having sight but no vision. And I get feedback, because it is feedback that sustains me in doing this kind of work. And I suppose one of the encounters was with a young woman working in risk management and patient complaints. And she came up to me one day at a meeting and she said, I heard you speak some time ago and I just want you to know I'm now doing my work differently. Of course I was intrigued. So I said, well, what's all that about? So she said, when I get a complaint file now and I open it, I say to myself, how would Kevin Murphy want me to deal with this? Neat. She's looking at it from the patient perspective. At a conference in Lisbon, an English doctor told me that when she heard Kevin's story, she said, it reminded her of why she went into medicine day one. It catapulted her back to where you are now today. And she said, there must be something I can do, and when I go home, I'm going to find out what that is. So when you marry that idealism of her youth, that enthusiasm, with her experience in the intervening years, she will certainly do something very worthwhile and of benefit to patients. Another said, maybe I don't have a gorilla. This was an academic, but I certainly have a few monkeys on my back. And I can assure you, you will have monkeys on your back. But it's how you carry them and it's what you do with them. And he said, your presentation he went on to say, I find it very difficult to talk of them for fear of showing my weakness and mistakes, I suppose, and how others will view me. Your presentation highlights all the more how we must all learn from our mistakes. It's already happening, but we still have a long way to go. I hope this generation of students will be different. And I do hope that you will be different. He also went on to say in that email, to share with me that his first night when he was in charge, his senior said to him, if you have a difficulty, please call me. And he was fine with that. And then there was a pause and the senior added, but take it as a sign of weakness if you do. Toxic stuff. Never let yourself be influenced by those kind of remarks. I hope they're no longer being made. But that is toxic stuff. When students accompany me on Kevin's journey and engage intimately with the shortcomings in his care, they say things, how do they not see it? We're only students and we can see what needed to be done. The last time I came here, I was followed into the street by a student who said to me, Mrs. Murphy, I promise I'll try and be the best doctor I can. We hoped, and I cried, because to be honest with you, that's what this is all about, that you would try to be the best doctor you can. So healthcare can really only be practiced in an open environment of lifelong learning, continuing professional development. And the truth is that for most part, we patients, we submit to care. We don't always have sufficient knowledge to even decide or to assess whether the individual or the organisation or the equipment is of the standard that will serve us best. So we really do depend on you. This means that the patient is sometimes disempowered in relation to making informed decisions about health issues, and that's a situation which brings espoused patient-centred care into question, as well as the concept of patient autonomy. And those issues are around communication between professionals, communication with the patient, the style of communication. I sit on the Medical Council, and I can assure you, practically every complaint has an element of how the doctor has communicated with the patient. It's the communication piece, when it goes wrong, that drives people to make complaints to the regulator. There's viewing the patient holistically and valuing the intimate knowledge the family have of the patient. There's a real resource there. The role of family advocacy on behalf of the patient, resisting the temptation to over-rely on past experience, and you saw how that affected the GP. The desirability of having the patient fully informed and viewed as a genuine partner in his care, and identifying danger times in the journey. The transitions. The handover for Kevin was appalling. Transition from one unit to another, that all critical information gets passed along the line. The dynamics of the care team. What do you do when you're the boss? You'll be in leadership one day. Will you facilitate your juniors to speak up? What about the time while you are a junior? Will you have the courage to speak up? Identifying dysfunctional teams and protecting the patient from those. Professionalism and integrity in the aftermath of the event, and the necessary supports for patient and family, and the necessary supports for clinicians in the aftermath of events. Collaboration and partnership has to be essential. The conversations have to occur, the difficult conversation. Dialogue has been described as powerful conversation. So now the onus is on each of us to see all of that translated into safer care for the raison d'etre of healthcare. And what is the raison d'etre of healthcare? It's the man in the bed. And that really must bring about ensuring a real sense of satisfaction as well for all of those working in healthcare. You deserve satisfying care, satisfying careers, and we deserve compassionate care. And I suppose I really do hope that all of this will come to pass. And isn't it so much better if we do bring it about through that partnership? And I'm not alone in holding that view. I have heard Jim Conway, Senior Vice President of IHI, describe that kind of engagement process as making the status quo uncomfortable while making the future attractive. And that's kind of how I look at us, we advocates, that we're a bit like the piece of grit in the oyster, making things sufficiently uncomfortable, but bringing about the pearl of healthcare improvement. The National Patient Safety Agency says that consumers of healthcare are those who, if you like, get the fallout. And the report Safety First 2006 says that those organisations that are most successful in patient safety are those that engage with patient and family. Lucian Leap said the time is now. If health and our healthcare are at the table, then the patient family must be at the table, and they must be at every table. Not next week or next month, but must be now. And that's why I'd like to, as I near the close of my talk, to share with you this excerpt from the London Declaration. It was an output of our workshop. In honour of those who've died, those who've been left disabled, or loved ones today, we will strive for excellence so that all people receiving healthcare are as safe as possible, as soon as possible. This is our pledge of partnership. It's our patient pledge of partnership. It's my Margaret Murphy pledge of partnership. And the way forward is we have the national standards. We have to see that the the culture is such that there are systems and supports that people, staffs, if are enabled to do that which they're asked to do. And it would be worth your while looking through those standards. They were published by HICWA. And Athol Gawande, he's a highly respected surgeon in the United States, he wrote in the New Yorker last year, when he was talking about the deteriorating patient, he said, more than anything, what distinguishes the great from the mediocre is not so much that they fail less, it's that they rescue more. And I suppose that's why what I'm really asking of you is that you would always be in that rescue mode, that you will spot the deteriorating patient, that you will respond to it. And at many points during his journey, Kevin sorely needed someone to rescue him. And my sincere wish is that all providers will resolve to operate out of that. And it's equally important that we, patient and family, take up, if you like, our baton, because we too have a vital role to play in the rescue exercise by highlighting and making sure that our voices are heard. So it is up to healthcare to issue the all-important invitation, and it's up to us to accept the challenge to be critical friends in a meaningful collaboration. And to end, when you look at it, wasn't I present at Kevin's birth? I know every detail of that birth. I was also present when he died, and as his mother, I needed and I deserved to know everything about the circumstances which brought that about. But over and above that, I needed to be assured that lessons would be learned, that the lessons would be disseminated, all in the hope of preventing recurrence. Because as Sir Liam Donaldson says, to err is human, to cover up is unforgivable, but to refuse to learn is inexcusable. So thank you very much for this time.